Okay, welcome back to part two. We're going to talk a little bit about the behavioral effects and the pharmacodynamics of benzodiazepines. So benzodiazepines were first isolated in 1955. They have a lower toxicity than barbiturates, so that made them very popular and put them in much higher demand. Especially in the 60s, they were very popular for middle-class women. I'm fairly sure the Rolling Stones song Mother's Little Helper is written about Valium. It sort of eased all of their anxiety about what was going on in the world and all of the things that they had on their plate. So they were very highly prescribed at that time as well. Now that we're more aware of the risks that come with benzodiazepine use, especially long-term use, they're not as highly prescribed anymore. We begin to recognize that abuse and dependence potential. There is fairly strong physical dependence that develops with benzodiazepines, and the withdrawal effects can be medically serious. So we have to consider that when considering a benzodiazepine prescription. It is currently used to treat anxiety, general anxiety disorder is what I mean by GAD, panic attacks, insomnia, seizures. So I'm saying in acute response to seizures. It can be combined with anti-epileptic medication, but it can also be administered immediately in response to a patient who is currently having a seizure. They are also used to ease alcohol withdrawal symptoms. So it can be alcohol withdrawal, as we'll talk about next week, is also very medically serious. You can die from it. So you need other medications to help modulate those withdrawal effects in order for someone to not have serious medical complications while going through that withdrawal. So that is one of the medical uses of benzodiazepine, is to aid with alcohol withdrawal. As I said before, the elderly have a lot of problems with the side effects and overdose of benzodiazepines. Typically, overdosing on benzodiazepines is quite difficult. They have a fairly high therapeutic index, but for the elderly, that therapeutic index starts to shrink because the metabolites stay in the system for such a long time. So as you see increasing dose of the drug, you can see different effects. So with more drug, you're having decreasing consciousness. So benzodiazepines are basically only going to be using this section. So alertness, relief from anxiety, sedation, and sleep. One of the problems that people find with benzodiazepines is that these two go together. The relief from anxiety is wonderful and can be life-saving for people, but the sedation effects can make it really hard to continue your life and function in that way. So that's something that really needs to be balanced with the dose for each individual person, and can vary between those short-acting versus long-acting benzodiazepines. So these relief from anxiety, sedation, and sleep, those are going to be our main, usually desired effects of benzodiazepine use. General anesthesia is going to be very difficult to achieve with benzodiazepines. They are commonly used as a prophylactic before a medical procedure. For example, if you go get your wisdom teeth removed, or if you're going to get a invasive diagnostic test, oftentimes the doctor will prescribe you one Xanax or one Valium to take 20 to 30 minutes before your procedure to help you sort of calm down. It can also aid the effects of anesthetics like not nicotine, Novocaine. So, but it's not typically used for general anesthesia, and you would need a really high dose to get into this range of general anesthesia, coma, and death. It is possible, but it's the doses between this sleep and the general anesthesia is going to be a really large gap, not linear the way that this graph suggests. So benzodiazepines are acting on the GABA-A receptor. The GABA-A receptor is an ionotropic receptor. It is a pentamer, meaning that it has 5 different subunits. So 1, 2, 3, 4, 5. The identity of these subunits is going to determine the effect that the receptor has. This receptor also has multiple binding sites. So we've talked about this with the NMDA receptor as well, but Benzodiazepines have their own specific binding site that is between the alpha receptor and the gamma receptor. That's what's being shown here. These are approximate locations, but it helps give you an idea. The GABA A receptor is a ionotropic receptor that lets chloride into the cell, typically, causing a hyperpolarizing effect. So these are inhibitory. With different combinations of these different subunits, so the alpha, beta, and gamma subunits are the only ones that we're going to consider. There are 5 different flavors of alpha subunits, and they are associated with different effects. You always need to have beta subunits, and most will have a gamma subunit as well. Remember, you would need a junction between alpha and gamma in order for a benzo to be able to bind. When you activate an alpha-1 receptor, shown here in red, you would expect to see effects of sedation, anticonvulsive, which is that anti-seizure, amnesia, so loss of memory, and possibly addiction. If you had a drug that just targeted alpha-2, you could get those anxiolytic effects and some muscle relaxation without risking the amnesia and addictions, right? So one of the things that's big in anti-anxiety pharmacology is trying to develop drugs that will target these two without getting the sedation and amnesia. So while those drugs have often been very successful within mice and mouse models, they don't usually fare that well in humans. But the main takeaway message here, though, is that different compositions of the GABA receptor, activating them is going to have different effects. Okay. So the long-lasting versus the quick onset and the potency of the drug is also going to have to do with how well it binds. So this is a ability to displace diazepam, which is a benzodiazepine. And if you are able to displace it in a really high manner. So how this is read is that a 9 means that you have a high concentration of free diazepam, which means that it is unbound. So the drug that is shown here has displaced the diazepam. So clonazepam shown here has a really high rate of diazepam displacement and a very low effective anxiolytic dose. So this is a linear relationship where if you are better at displacing diazepam, you can be used at a lower dose. If you don't displace it as well, you're going to need a higher dose. So this is the way benzodiazepams affect the GABA A receptor. Benzodiazepams are what we refer to as a positive allosteric modulator. They are not a pure agonist. Benzodiazepines do not activate GABA receptors on their own. You need both the presence of GABA and the presence of benzodiazepine to achieve their effect. That's what's being shown right here in C, right? Benzodiazepine is bound to its own specific binding site. Remember, it binds to a site that's not the same as GABA. It binds to an allosteric modulator site. That is not sufficient to open the channel. You need both. GABA on its own can still bind, and chloride will still move through this into the cell. But in order for benzodiazepines to have effect, both will bind and more chloride ions will enter the neuron than with GABA alone. So benzodiazepines facilitate GABA binding. They seem to have an effect where they change the affinity for GABA so that each binding event of GABA has a larger postsynaptic effect. So that's what's shown here. These are recordings of currents, right? We're looking at the nanoamps over time. So here's the current that we would see from GABA, right? There is a small hyperpolarizing current when you apply GABA to the cell. If you apply just diazepam, you do not see anything, right? You need GABA and diazepam together, and when you combine them, you get a magnified effect. So this is that positive allosteric modulation that we're talking about. And this is the shift that we would expect to see on a dose response curve. So here we have a dose, we're looking at GABA concentration. So this is looking at a cell and looking at current amplitude, which is what this would be showing too. This is a current amplitude. So they the response that they're measuring is current amplitude, and you can achieve higher amplitudes at lower doses of GABA when it is combined with diazepam, right? So we're lower concentrations of GABA plus diazepam can achieve a larger current amplitude. Okay. And that effect is blocked if you add a BDZ antagonist, right? So you can also, if you add a GABA antagonist, the BDZ is going to have a very minimal effect. There is still some effect because remember that GABA antagonist is not going to have 100% occupancy, right? It is very possible that you will have still some receptors that will bind GABA or bind GABA and benzodiazepine, and that GABA antagonist would not bind if you had a competitive antagonist. So this is a dumb analogy that I think can be helpful, but I want to sort of compare the way benzos and barbiturates act at the GABA A receptor because it can make a big difference in understanding how much you need and why the therapeutic index is so different. So they are both allosteric modular. They bind to different sites on the receptor. Benzodiazepines increase the affinity for GABA, as we said. They are not effective in the absence of GABA. You need GABA in order for benzos to work. Barbiturates can cause the channel to stay open longer after GABA binds to receptor. However, barbiturates can open the channel on their own in high doses. They don't need GABA in order to work. One dumb way of thinking about this that I often find is helpful is thinking about the GABA receptor as a bouncer. So just like a normal bouncer, the GABA receptor will open the door every once in a while. When you add benzodiazepine, the bouncer will still only it'll have a normal opening. It'll only let in one person at a time as usual, but it's going to open the door very frequently. So benzodiazepines sort of help increase the frequency of GABA receptor, of GABA binding to its receptor and opening, which can lead to a larger macroscopic, thinking about neurophysiology right now, a larger current on a big scale. Bouncer with barbiturates, it's basically the bouncer doesn't change how often it opens the door, but each time it opens it, a ton of people flow in. So it's a bigger magnified effect. Because they can act on their own, they don't require GABA, and each opening event is going to have such a huge current effect. The therapeutic index for barbiturates is much smaller. They come with a much bigger risk. Okay. So that is it for behavioral effects and pharmacodynamics. The next lecture is going to talk, or the next section is going to talk about addiction.